Hi, this is Michael Altos, and we are continuing our discussion about the GI system and antihistamines, and this is part 3. So now we're going to talk about postoperative nausea and vomiting, which is a major topic and really beyond the scope of a pharmacology lecture. But you need to make sure that you've learned about patient-specific and procedure-specific risk factors for postoperative nausea and vomiting. And we've already discussed a lot of information about anesthetic agents and techniques that affect likelihood of postoperative nausea and vomiting. And as always, the first step in treatment of PONV is to rule out things that are important to treat, like hypotension, hypoxia, hypoglycemia, increased ICP, and gastric bleeding. This slide shows some of the different risk factors for PONV. And you can review this yourself. Some of them are positive risk factors, some of them are conflicting, and some of them are considered to be more limited or disproven. Classically, we've said that the 4 primary risk factors are female gender, non-smoker, prior history of PONV, and receiving opioids. And just with these 4 points, we can show as risk factors increase, risk of PONV steps right up. And we can also show that as we add in more and more drugs that treat PONV, we can decrease their risk quite a bit. This may not be significant in someone who has a very low risk of PONV, but in someone who has an 80% risk, you can see that the risk drops off significantly with each additional intervention. Medications that treat postoperative nausea and vomiting primarily work in the brainstem, either in the vestibular center or the CTZ, the chemoreceptor trigger zone. The first and probably the most common class of drugs are the serotonin receptor antagonists, specifically 5-HT3 receptor antagonists. This would include Zofran, which is ondansetron, and other related drugs like dolasetron and granisetron. These are most effective when given at the end of surgery, and the dose for ondansetron is 4 milligrams, dolasetron 12.5 to 25 milligrams, and granisetron 0.35 to 1.5 milligrams. The most likely side effect is headache and prolonged QTC interval. Dexamethasone is a steroid that we've discussed previously. It is effective for postoperative nausea and vomiting prophylaxis with an unclear mechanism, but clearly something in the CNS, probably in the medulla. The normal dose is 4 or 5 milligrams IV given at the induction of anesthesia, and it's as effective as a dose of Zofran. I don't usually repeat this dose, so 1 dose only, and there are some studies that support giving higher doses up to 0.1 milligrams per kilogram. Are there significant adverse effects when patients are given dexamethasone? Well, studies are conflicting. We know that steroids increase risk of infection, and it's not clear if patients who get dexamethasone have increased risk of wound infection. Similarly, we know that steroids increase blood sugar, and dexamethasone might not be the best choice in patients who have very hard to control diabetes. As we often see, the risks and the benefits need to be compared. Butyrophenones are also drugs that we've discussed before when we spoke about psychiatric medications. These are drugs like Droperidol and haloperidol. They are very effective for PONV prophylaxis by blocking central D2 dopamine receptors. The dose for Droperidol was 0.625 to 1.25 milligrams IV, which was at least as effective as 4 milligrams of Zofran. For Haldol, most people give a milligram, but the published dose is between 0.5 and 2 milligrams. These drugs are most effective given at the end of surgery. Side effects include sedation, anxiety, restlessness, and dystonia. Droperidol, unfortunately, was given a black box warning by the FDA, warning of risk of torsade in patients who have long QTC. Now, this is controversial because it's unclear if it's really clinically relevant, especially at the low dose that we were using for PONV. It's probably no less safe than ondansetron. And the QTc prolongation you get with either droperidol or ondansetron is no worse than with either drug alone. Nevertheless, if you're going to give droperidol, if it's available to you, or haloperidol in its place, it would be appropriate to monitor them by ECG for a couple hours. Antihistamines, which we just discussed recently, are also useful for postoperative nausea and vomiting. Diphenhydramine, which is Benadryl, dimenhydrinate, which is Dramamine, and meclizine, which is Dramamine or Antivert. These drugs work by suppressing the vestibular neuronal firing, and they're also anticholinergic, and they also have sedative effects, and they're known to be effective for motion sickness, and may be helpful in postoperative nausea and vomiting as well. The usual dose of Benadryl is 12.5 to 25 milligrams IV, and the most common side effects are sedation and anticholinergic side effects like dry mouth and urinary retention. Phenothiazines include promethazine, which is Phenergan, and prochlorperazine, which is Compazine. These drugs also work on the D2 receptors in the CTZ and other parts of the brain, and they also have some antihistamine and anticholinergic activity. I like to use promethazine, 6.25 to 25 milligrams given IV or IM. It can be given at the induction of anesthesia, although I usually save it as a rescue medication for PACU. There is quite a bit of sedation, especially at higher doses, and there is risk of extrapyramidal symptoms due to its dopamine antagonist mechanism of action. Promethazine also has some risk of vascular necrosis, and so at our hospital it needs to be given either IM or else as an IV infusion, not as an IV bolus. Metoclopramide, or Reglan, is something we discussed earlier. But now we're going to focus on its central D2 receptor activity. And this is probably part of the reason it's antiemetic, and also because it's prokinetic, so it helps empty the stomach. It's really no longer a first-line therapy for PONV. And especially at the 10 milligram dose, it's likely to be ineffective. If you really want it to work, you'll probably need more than 20 milligrams, and you can go up to 50 milligrams, but you really do see a lot of side effects at these higher doses, especially in awake patients. We see hypotension, tachycardia, and also some dyskinetic or extrapyramidal symptoms at high doses. These can be attenuated if you treat with benzodiazepines or antihistamines. Anticholinergic drugs like scopolamine are effective against PONV. The scopolamine patch is the most common form of administration. Scopolamine antagonizes muscarinic receptors in the cerebral cortex and in the pons, as well as blocking histamine receptors in the hypothalamus and the vomiting center. Now, a scopolamine patch takes several hours to start working, but the effect lasts for up to 72 hours. Side effects include blurred vision, dry mouth, dizziness, and agitation. And the PONV effect is really limited to scopolamine. We really don't see much effect with the IV anticholinergics like atropine or glycopyrrolate. There are substance P antagonists like aprepitant, which is called Emend, and it blocks the NK1 receptor. It may also augment the activity of ondansetron and dexamethasone. The recommended dose is 40 milligrams taken orally within 3 hours before induction of anesthesia. It is expensive, and the timing is not convenient. Side effects include constipation and hypotension, and an IV formulation may become available. Other treatments that you may hear about include ephedrine, which is not a first-line therapy, and the evidence and the mechanism are really unclear. The dose is 25 to 50 milligrams given IM at the end of surgery, and the mechanism is not just increasing blood pressure, but something else. Propofol clearly has antiemetic properties, even in the subhypnotic range. You can get this benefit by using it as an adjunct to anesthesia or as a TIVA. Usually the propofol should be run at least 20 micrograms per kilogram per hour. Some people have used it as a rescue therapy in PACU, as a bolus of 10 to 20 milligrams IV, but the duration of action of this treatment is probably going to be short. Finally, other options that exist include midazolam, hydration, acupressure at the P6 point, low-dose Narcan, ginger, and then some questionable treatments that include supplemental oxygen and inhaled fumes of isopropyl alcohol. That's it for this recording. Thanks for your attention, and please let me know if you have any questions.